blood, and it's recirculating. So all you're doing is cleaning the same blood over and over again. You're not getting the general circulation of the patient. But this problem, another problem with them is the patient can't take baths or showers. If they do, we usually say, well, you really have to do it before dialysis and cover it with saran wrap or something, because if it gets damp, that's when you get like pseudomonas, little bugs kind of living under the dress, and the next thing they get like an exit site infection.
Do you have problems with some of your drug user patients using that nice little accent?
Oh, they always, yeah, they've always claimed that, yeah.
Well, they're not
honest.
honest.
They don't touch that, no. But the fact that it's got a different coloured cap on, or no cap at all, or there's tape around the cap.
Oh my god.
You know.
I'm sure the shower is the least of their worries over there.
Yeah, I mean, it's yeah. So we usually, you know, try to get them out of those patients. So, so these are things. Only dialysis RNs can access a dialysis CDC. We're going to go a little bit more into that for when you guys are in the unit. So locked up in normal saline. So lumen length is usually about 1.7 to 2.4. It actually says it on the lumens. One's slightly longer than the other because you want that distance for the blood going in and out. It's strict aseptic, non-touch technique. If I'm putting a dialysis catheter on, it takes me about 4 minutes. By the time I've done the 3 changes of gloves, the 1 minute rubbing of the alcohol down the lumens, and the hand alcohol sanitizer, and you know, it takes a long time to put a catheter on these days. They've definitely got more strict on the technique, where in the old days we just like, oh, in, done. And you have to wear masks as well, because most, you know, when the patient wears a mask, because most bugs live up your nose. That's where your MRSA tends to hang out. So, and then if we are going to give them a bolus of heparin, we'll usually give that then, and then we'll hook them up to the machine. So that's kind of like the difference. So you might see a patient with a temporary catheter. That one's known as, you might have heard the term the haircut. It's the one that's on the left-hand side. It's got the 2 curved lumens. It just pops down into the jugular there, and it drops down straight down in through to the subclavian, down into the vena cava there. And then the other one's a tunnel catheter, and you can kind of tell the difference, usually the position on the patient's chest. They actually have like a little cuff under the skin. On really skinny patients, you can actually see that cuff, but you can otherwise you can feel it sometimes, and you'll actually see it come up because they like to loop down into the jugular. They try to avoid the subclavian now because of stenosis issues, causing problems for blood circulation into the arms, if we're thinking about now what to get a fistula formed in these arms. The other problem with it is patients that have multiple access problems, time and time going in again, and they get stenosis. You can even get dialysis patients that have got huge banding JVDs and all this collateral circulation, and I've even had them where they'll go into like their eyes will swell up, their ears will swell up, because you've affected the pressures in these vessels and fluid is being shunted into those spaces. So they usually have to go in and get you know, catheterizations and meshes put in to kind of open up those vessels. It doesn't happen as much. They start to really be more prudent with vascular management and teaching vascular surgeons this is what's best to create vascular access. So that's a close-up. That's another type that you might see. These are usually taken out before the patient leaves hospital. But see, you've got the red and the blue side, which is the dialysis access, but then you've got that third little lumen, and that's an IV fluid access that the nurses can use in the hospital. We like these, like, because I can use that. And it's just kind of showing the length of them. They're a pretty flexible plastic tube that has holes on the end. And there's an actual patient. So if you can see on the right side, you can see where that's a permanent catheter. You can see how it loops over, and it's going to bend down into the jugular and then down into the vena cava. So fistulas. Fistulas have been around since at least the 1960s. The first one was called Camino. It used to be created down at the wrist. Basically, the first thing is they're going to get to a surgeon. They're going to do Doppler US mapping. They're going to basically look what blood vessels this patient has. They might even, before they create the fistula, see that they need to maybe tie off some vessels that are maybe like collateral vessels that have already been going on, just to try and make the main basilic and cephalic veins healthy. And then the idea is if you join an artery to a vein, that arterial blood, which is at a much higher pressure, is now going into a vessel which is not used to that high pressure. And so that high pressure then gets into the vein, increased blood flow, and it's going to basically stretch the vein out like, and it looks varicosed, but basically the vein shouldn't look that big. It's because of the high arterial blood flowing through it. And now we can actually access it. We can actually get a big needle in there, and we can run the flows up to, sometimes up to 500 mils a minute is what we're running. So it usually takes about 2 to 3 months. And while it's developing, usually, like I say, they'll have a catheter in. And we're super happy. We actually get awarded points for like not having catheters on the unit. It's a big drive. We actually get cash bonuses.
Yeah, the beta, right?
Yeah, through the beta. Yeah, it's like all incentives. Like if you're meeting these goals for the patients, they'll actually give you cash bonuses. So it's huge incentives, and we usually like really make a celebration when the patient gets their dialysis catheter out. You know, we'll give them a little treat, give them a certificate. Anything to make their life a little bit better on the machine. Yeah. So that's kind of like a diagram showing. They're tending to use more of the upper vessels now because they are bigger. In the past, it used to be they got the wrist because they were easy access. But now they've actually figured out how to get into those big vessels. Because you've got a beautiful vessel, but it hides underneath the muscle. So sometimes you have to do more manipulation to get that to join. Then on the bottom, that's just a little image of a graft, which I'll talk more about. But basically, you use the vein and the artery and you just hook some synthetic material in the loop to get that blood flow. So the patients get told that basically they should be looking for a thrill and a bruit. So basically they should be feeling their fistula, make sure it's not like hot, looking for signs of infection, and that they should be able to feel it and hear it. Most of them can just feel it, they don't have to necessarily listen to it. But if they can't feel it, we then say listen to it. Because the quicker you can intervene with a clotted fistula, the more likelihood you can actually save it. So we'll tell them, hey, no, go straight to the ER, get it fixed. So they can't have any IVs on that side. So if you have a patient with an AV fistula, no IVs, no matter how nice that collateral vessel off the side of the fistula looks, no IVs.
Okay, so I have a question actually. We had a dialysis patient this morning.
Oh, you did?
Yeah. So fire was starting an IV when we got there. God love them. But so they started it in his hand, but his fistula was up here in his. Okay.
No, not even blood draws.
Was not.
And then they gave atropine.
I'm not going to ask. Yeah. No,
His fistula was
nothing on that arm. Absolutely nothing, because you don't want to run the chance of introducing infection or cause any kind of
Let's bring credit for that IV because that was
into that arm. Because if you lose that fistula,
arm, right?
you're almost killing
I
that.
had a case where I had a patient with 2 fistulas, and she was very, she was critical. She was
Okay.
right in front of 26.
So it was one an old one and one new one. She was using
She
one
just
and not the other.
had one place, but the staff at work, the facility, I don't know the name of the staff, but they couldn't even remember when the last time she had dialysis.
Okay.
And they couldn't tell me which one was the
Got that.
Impatient.
So,
He would be
patient
the
was
best
going
one.
downhill, and I just started one like.
Okay. If you do start one, start it obviously first away, be really, really strict on your technique. But you know,
Yeah.
patients do go from arm to arm. You know, they might have had a graft in here that failed and clotted. And then they've gone for a fistula here, or they've got a fistula above it. I know it's really hard to tell sometimes.
Yeah.
You know which one's working by the one that's vibrating and it's flowing.
Which
Okay.
both were.
What we do.
were, but-
So in that situation, if you did know which was the
And
newest
they couldn't
fistula,
tell me.
because they're creating a newer fistula for a reason. They've obviously got problems with that old one. I would stay away from the new one. You want to give that new fistula every opportunity to grow and develop for that patient. So if you're stuck and you really can't use the feet, because I would suggest, like, if you
She
could.
had such
use
bad
it.
edema.
Yeah.
I mean,
Yeah, and
I
that's
only
it, they're
had
very
one
tough patients.
access, and I was
Yeah.
like,
You often find that they'll have vessels like mapping across through here because they get collateral vessels and because of the congestion that they have, especially if they've had central lines, you might find a vessel through here. And sometimes, even on an edematous patient, I'll do that in the hospital. I will go up here on women to the breastbone and start feeling through here and see if I can find any collateral vessels. But yeah, the other thing they can't do is lift heavy weights. I've had patients, like guys especially, they were lifting logs for the fire or whatever. That pressure causes a disruption in the blood flow. It doesn't take much for a disruption in that blood flow for that to then cause the vein to basically get sluggish and blood clots start happening because it's not used to having that flow.
Poor guy this morning.
And then they can't bump, cut, you know, they've got to be really careful about getting infections in their arm. The other thing, no circumferential wrapping. So when we put the pads on, it's simple tape, never wrapped around. We'll use a tourniquet briefly when we put the needles in, but after that, no tourniquets. Bad habits used to happen when instead of sending a patient to a surgeon and say, hey, we're getting problems with the vessel collapsing, there's blood flow issues, they say, oh, we'll just tie a tourniquet on. I saw this down in Camarillo, I was shocked. I said, what do you mean you're tying a tourniquet on the arm throughout the whole dialysis? Well, it's because they're not getting blood flow. Well, that means they've got a stenosis, they've got an outflow stenosis. You need to get them to the surgeon. That's fixable. You do not do that. So people have some bad habits. And then when they do have those wraps on, we usually tell the patient 6 to 8 hours. So if they have dialysis in the morning, before you go to bed, take those wraps on. No tight clothing. I've seen jewellery cause problems with fistulas, watches. And then, like I say, they get told to watch out for infections. So why we like fistulas? Basically, the lowest chance of infection. They've got great blood flows. We can actually then reduce the dialysis time if we're actually able to get the blood out and circulate and filter it and clean it. It's actually less expensive to maintain because they are going to the hospital less to get it fixed. It's actually considered the gold standard, so all the units are pushing, even in the old people that we never thought we'd get fistulas in. Like I've had patients in their 90s have fistulas. They got them placed in their late 80s and they're still using them at 94. Because we can send them back. It mightn't necessarily work initially, but they can go back in there and they can reroute blood vessels. Patients don't like them because obviously it means a needle going in. We try to limit lidocaine use because lidocaine will cause scarring tissue, it will cause white blanching. Then down the line causes problems with maybe that fistula, having bleeding problems when we take the needle out. Large needles, bulging, disfiguring, something called steel syndrome. You might hear about patients talking about like their hand being cold on the inside. They'll get pain because basically it's stealing blood. That arterial flow which normally would feed the hand, you know, most of it's now getting whacked back up this vein, back up there. Well, the hand's like, ooh, I've got no circulation. I'm painful. We have to put hot packs to help dilate the vessels in the hand until we get them to a surgeon who hopefully can remap it. And then sometimes they just take a long time to develop, and we just never get them to work, so they can't have fistula. Usually then they'll go to a graft. That's just showing you, like, this is a 14-year-old fistula. You can see the white scar tissue on that vessel. They do bulge, they get aneurysms where they keep getting used, because you imagine that blood flow going back and in and out. It's really turbulent inside that blood vessel. I remember veins have valves, arteries don't. So valves are usually the weak part of a vein. That's why when you start an IV, stay away from the valves. They're difficult to thread and they're a weak spot. And then you see there, they've got like little collateral veins that are also filling. And you can see that vein going down through the bottom of the arm. This is an aneurysmal AV and it can get this big. Yeah, it's a snake, it's an anaconda for sure, and that should have been surgically corrected way sooner. Yeah, now, I'm showing you that because they do happen, and the problem with these fistulas is if they get overused and
please call extension 210.
Get used in one spot, that vessel, the wall gets weak. And if that thing goes, that is the only time I might say to you use a tourniquet. So, yeah, so if you go to the dialysis unit and say it's ruptured, I've only seen fistulas ruptured a couple of times, usually because of infection. The infection gets in there and they get like all of that fluid going into that tissue, it weakens it, and then you've got that high pressure inside that vessel, it ruptures, and it will just blow like crack toilet. And it's the only time that I would literally say, maybe use a tourniquet to slow down the flow. You're just basically going to do direct pressure, get them to the ER, and you're going to probably say to them, you might want a vascular surgeon because this fistula is ruptured. But yeah, what's interesting, you see how, like, on the shoulder there, so you can imagine what's also now happening to the circulation through to his head and his jugulas. Yeah. This guy probably would cause a shunting of fluids, and he probably gets swollen head and neck as well. So they're bleeding problems. That's why I pretty much covered that. The only thing, so you go to the dialysis unit, most patients stop bleeding within 15 minutes. Sometimes they won't stop bleeding. It could be because of their diet sometimes, like high vitamin K, like we've been doing that, the heparin. They're on Coumadin because a lot of them have heart problems, they've had heart issues, and they've got atrial fibs, they're on Coumadin. Most times you can just do direct pressure. Don't keep looking. You're going to do the 10-15 minutes. That's usually what you're doing at the dialysis unit. We try little tricks. We used to have protamine, which is the reversal agent for heparin. Don't have it anymore. You can use a tea bag. The tannins actually help the blood clot. But what I've found is the blood tubes. There's a little bit of sticky stuff in the bottom of the blood tube. If they're really having problems, stop bleeding, get a Q-tip, get the agar, the stuff at the bottom of the blood tube, put that directly on, put the Q-tip down, put a gauze pad on it, and then get them over. Because usually what's going to happen is the ER doc's going to put in a purse string suture, because the skins just won't heal together to stop bleeding. But I've had them up to an hour where they won't stop bleeding. Get the blood pressure.
You guys have like a C-clamp device, right?
Yeah, we use clamps, but sometimes you're actually better off doing your own pressure. Because the problem happens is, as soon as so that clot starts to form, you've got the pressure on, as soon as you release it, the blood pressure kind of like under that vessel's there, and it just totally throws the clot up again. So the reason I don't like clamps is because it does a sudden release. So if I've got a bleeder, I'll have the clamp on initially, then I will hold it, and then slowly release the pressure, and hopefully it will hold the clot, so it won't blow off. And I'll kind of do it. We're good. Okay. They also have something called tip stuff at the unit that we can use. And basically it has it's like a band-aid, and there's a little disc underneath, and it basically has this special material that will help form clot. So grafts, they're a little different. That's the one I was talking about, the synthetic material. They're getting a lot better than they used to be. They were really pushed in America more than any other country because the graft is probably driven. Because these are the new thing, we can use it straight away, get it in there. Well, the problem with the graft is it gets infections and it clots really easily. So you're finding like AV fistulas, if they're well managed, can last over 20 years. A graft, a couple of years, 5 years max. So they've definitely moved away from graft. These can take a long time to stop bleeding because again, if there's repuncturing of an artificial material, there's no real healing going on, you just got thrombus. They can be, they're usually within, sometimes a couple of days, but usually you leave them a couple of weeks for the swell to go down. It's pretty painful for the patients. They literally, the surgeon puts like a metal rod under the skin to create a tunnel, to thread that. So there's a lot of, so you might have one at home, the patient might call and say there might be a problem, they might have just got the graft in. Their arm might be really big, swollen, hot, painful. Probably should just take it to the ER just to make sure. But for the most part, it's usually just hopefully not an infection, because they are prone to get infections on insertion. So there's like the picture. So basically you have arterial flow coming one way and the venous next. They get really high pressures in those. They sometimes have what we call pseudoaneurysms, where you get a little balloon to the side of the graft because it's like the weakness of that material, and it just kind of causes a little aneurysm.
I'm old school, but they call that shunts too, right?
No.
No.
No. I didn't show the picture of shunt. I was waiting to see if anyone said shunt. Shunt gets way misused. Now a shunt, that's internal. It's a graft that is internal from an artery to a vein. A shunt was external. A shunt was actually one of the earliest forms of dialysis access. Used to especially get used a lot in kids, and it was always on the wrist. And what you would see is they would literally go into the artery, sew on a plastic tube. So a plastic tube to the vein, they would actually bring it, there would be sutures, they would bring it out, and there used to be a little connector. And I have used them. And that was a shunt. It's shunting blood out of the artery back into the vein, but it's external. Yeah, I've noticed a lot of people say, oh, they've got a shunt. No, I haven't seen shunts for years. We used to have to test the direction of flow. It was kind of interesting. We used to have to introduce a little air bubble. We used to like clamp them. Hook it, introduce a little air bubble, put it back together, release the clamp and see which direction it went. So we knew which was artery and vein. So again, I think I've pretty much gone through them. They're just limited. They can get Steele syndrome as well. One thing that is nice about a graft if the patient's had it, because it does go into the artery vein, it's forcing arterial blood back into a vein, we can actually then sometimes use a graft